The following podcast is part of a certified educational activity titled Advancements in IgA Nephropathy, Discovering the Potential of Complementary Pathway Therapies. Access the entire activity and complete the post-test at peerview.com/XJK860. Downloadable slides and practice aids are also available.
Hello, let me welcome you to this program, Advancements in IgA Nephropathy, Discovering the Potential of Complement Pathway Therapies. My name is Dr. Gerald Appel. I'm a full professor at Columbia University and the director of the Center for Glomerular Diseases at Columbia University in New York. My co-speaker will be Dr. Dana Rizek, who is a full professor of nephrology and medicine at the University of Alabama in Birmingham. And she also will be talking about this very important disease entity, IgA nephropathy. So our goals for today are to increase your knowledge of IgA nephropathy pathophysiology, to let you have strategies for managing patients with IgA nephropathy using the latest guidelines and trial data, and to provide guidance on how to implement emerging therapies that target the complement pathway. First, let's talk about the pathophysiology and identification of IgA nephropathy. So this slide shows you glomerular diseases and their uncommon occurrence. Now, if you take glomerular diseases, they're not as common as hypertension or diabetes. Some of them are very rare. Some of them are uncommon, but not very rare. So if we look at these, C3 glomerulopathy is extremely rare. Very rare disease with very few new cases per million. Atypical hemolytic uremic syndrome is also equally rare. Then we look at IgA nephropathy, significantly more common than those diseases. It's a disease that I would see every day in the office of a glomerular center. And of course, something like lupus nephritis is even more common. So if you look at these, there's a variability in them. But again, IgA nephropathy is someplace in the middle of these glomerular disease in terms of uncommon occurrences. The pathogenesis of IgA nephropathy has been beautifully worked out over the last several years. The four-hit hypothesis is what we all base our understanding of the disease and as well as much of the therapy of the disease is targeted at this four-hit hypothesis. Hit number one is due to elevated levels of galactose-deficient IgA1 that are circulating. Secondly, you form autoantibodies. If you have IgA nephropathy, your IgA1, galactose-deficient IgA1, becomes antigenic, and you form autoantibodies against it. You then form circulating immune complexes of the galactose-deficient IgA1 and the antibodies against it. And these immune complexes land in the glomerulus, in the mesangium, and sometimes along the capillary walls, and then they activate the mesangial cells, they stimulate activation of complement, they cause inflammatory features to occur here. All of this leads to glomerular damage. So you can see with 4 different hits, there are multiple places where you could act to treat IgA nephropathy. Now, one of the important things is screening and diagnosing the disease. If you can't diagnose the disease and you can't find it, you can't treat it. So there are a number of ways that this appears. Screening, looking for certain features. So some patients present with gross hematuria. Often young people will do this. It'll come on after an upper respiratory infection or a sporting event, and all of a sudden, they'll have gross hematuria. But more common is persistent microscopic hematuria and or proteinuria. Along with these, there are other features like slowly progressive renal decline. This is another one of the things that you can have. The diagnosis can still only be made by a biopsy, and our view of this has changed. Right now, we think biopsy should be done on all adults with proteinuria over 0.5 gram a day or its equivalent in whom IgA nephropathy is suspected. If you have another diagnosis, that's different, but if you're suspecting it, you should be doing this. Once it's diagnosed, then you rule out secondary causes. And there are some common secondary causes: liver disease, inflammatory bowel disease, hepatitis B and C, that all of these autoimmune diseases, any of these can be associated with a picture of IgA nephropathy. So again, you either get the secondary causes and then you tune towards the primary causes. So I'd like just to turn to my co-speaker here, Dana, for a second, and say, Dana, in your practice, first of all, how often do you see patients with IgA nephropathy, and how do they present most commonly in your practice?
So, Jerry, just like you, I have somewhat of a skewed practice. I do run the glomerular disease clinic at the University of Alabama at Birmingham. So, I do see IgA nephropathy on a weekly basis. Again, because UAB functions as a referral center for that particular disease. Most often in adults, I see patients just like you described who come in with either microscopic hematuria, proteinuria, or already an elevated serum creatinine, so already established kidney disease. And they can be found either by their primary care physician during life insurance testing. So most of the time, patients don't have any symptoms by the time I see them, but they already have established and sometimes advanced disease.
And that is unfortunately very common, that the disease is often advanced already by the time we pick it up. That we don't routinely screen patients at every visit for urinary dipsticks with urinary dipsticks. But again, that's often what it is. It's insurance physicals, army physicals, sports physicals, pregnancy. That's where we pick up a lot of the patients. Now, this slide shows you the microscopic features of IgA nephropathy. In the upper panel, the light microscopy there usually just shows a little bit of mesangial hypercellularity, almost nothing more. That some, of course, can be much more proliferative and have even crescents. But again, this is not the typical thing, it's just this mesangial hypercellularity. Looking over at the green on black there, the IgA by immunofluorescence here, that the mesangial deposits are almost always found, even if there's some capillary wall involvement. And then the electron microscopy, the two bottom features. One shows involvement by the arrow of a mesangial electron dense deposit, an immune complex deposit. But the other one shows it, yes, but bursting out along the capillary wall as well. So again, electron dense deposits are there, and of course, they're due to the immune complexes which have landed in the kidney. We have an excellent scoring system for IgA nephropathy. It's one of the diseases where the pathology scoring system has made a clear difference in terms of how we look at the patients. Not that you're going to use it for treatment all the time, but for diagnosis and to give you an idea about prognosis. And there is mesangial hypercellularity. Now, this requires to get the M1, the bad diagnosis, you have to have over 50% of the glomeruli showing the hypercellularity. There's endocapillary proliferation, either none or one if you have any of it. Segmental glomerulosclerosis, either absent or even one glomerulus with it. Tubular interstitial damage, fibrosis, graded 0 to 25%, 26 to 50%, and over 50%. And you can see that's a T0, T1, T2. It's heavily weighted because that's such a bad finding in any glomerular disease. And now it's not only the MEST score, it's the MESTC score, where crescents have been added. If you have crescents, inflammation in Bowman space here, C0 is absent, but even one crescent raises that up. If you have 0 to 25% of the glomeruli with crescents, you get a C1. And if you have more than 25%, you get a C2, which again is a bad prognosis. Now, one of the things that has been developed, which I think is very important, is an international IgA prediction tool. If you look at these features, estimated GFR, systolic and diastolic blood pressure, proteinuria, age, race, use of ACE inhibitors, ARBs, and the MESTC score in terms of this, and other immunologic drugs that you're using, if you put those together here, you have a scoring system where it can tell you what the prognosis is. And it can tell you if you're going to have a 50% decline in GFR or kidney failure at up to 7 years from the kidney biopsy. So this can be a very useful tool at the time of biopsy or 1 or 2 years after the biopsy. So, Dana, how often do you calculate the International IgA prediction tool for your patients?
Every time I see a patient around the time of biopsy, and then after implementing some therapies, I recalculate it either 1 or 2 years at the time of follow up to see if I've made a dent in their prognosis. So I find it very helpful.
I use it a little less frequently, but I use it mostly when I have somebody that I'm trying to impress with them how aggressive IgA can be, even if you have few findings in the beginning. If you look at the prediction, and this is done on many, many patients, these are evaluated, and it shows that it's going to be a progressive disease. All of a sudden, now the patient will realize that's their chances of ending up in renal failure 4, 5, 7 years from now. That's pretty dramatic. So the tool has a lot of ways you can use it, and different people will use it differently. So at this point, I think we're ready to go on and hear a little bit about management and guidelines. And Dana will take over for this.
Thank you, Jerry. So that leads us into talk about current management and guidelines. And I'll start by saying that the last guidelines, the KDIGO guidelines, were published in 2021, and we are now in the process of having new guidelines updated. The ones I'm going to share with you are still in draft format, so they might change slightly once they're fully published, but it'll be worth looking at them and highlighting the differences compared to the previous guidelines. And I would say one of the biggest differences is looking at IgA nephropathy as this higher risk disease than we had thought about previously, and think about the management as targeting the immunologic side of the disease. So that's what the guidelines refer to as managing the IgAN specific drivers for nephron loss, but also managing the genetic response to IgA nephropathy induced nephron loss. So essentially, the chronic kidney disease that results from IgA nephropathy. And this is a significant departure from the 2021 guidelines, where we did things in sequence. We now are doing them in parallel at the same time, addressing these two arms of management. So if we focus on the IgN specific drivers of nephron loss, we will try to reduce the pathogenic forms of IgA, the ones that Jerry just mentioned, galactose deficient IgA1, but also the immune complex formation. And we also would want to reduce glomerular inflammation. And to that end, we're going to discuss some of the therapies that have recently been approved, such as Nefecon, but also the complement inhibitors, in particular, iptacopan. And on the genetic response to IgAN-induced nephron loss, of course, we want to continue with some of the previously mentioned and established therapies that we have. And I will go through some of the newer therapies that include SGLT2 inhibitors and endothelin inhibitors, specifically sparsentan. So when we talk about supportive care in IgA nephropathy, we again are trying to manage the consequences of the IgA-induced nephron loss. And we should address with the patient's lifestyle modifications that includes dietary sodium restriction, smoking cessation if they happen to be smokers, weight control and weight loss if they are overweight or even obese, exercise as appropriate. Blood pressure control is quite rigorous. The target is less than or equal to 120/70, but keep in mind a lot of these patients are young and can handle these relatively low blood pressures. That becomes particularly important in proteinuric patients. And to achieve that, you have to have patients on RAS inhibitors, so renin, angiotensin, aldosterone system inhibitors. We can also add dual endothelin angiotensin receptor antagonists. And in this day and age, we also have SGLT2 inhibitors, and I'll go through the data supporting the use of these newer drugs. And of course, every CKD patient is at risk of cardiovascular complications, and these risks need to be managed. That includes managing, for example, hyperlipidemia. So SGLT2 inhibitors, of course, have been tested in diabetic patients with kidney disease, but in also patients that don't have diabetes but have chronic kidney disease. And there are two major trials that I will briefly mention here: the DAPA-CKD, which enrolled close to 4,000 patients with chronic kidney disease. And of those patients, about 254 had biopsy confirmed IgA nephropathy. The primary endpoint for that trial looked at the composite of the sustained eGFR decline of at least 50% or higher, the development of end-stage kidney disease, or death from kidney disease related or cardiovascular causes. And as you can see, patients in the dapagliflozin arm, which are depicted in the bottom curve, fared much better than the placebo group, with a hazard ratio of 0.29 for these primary endpoints. It's important to note that the IgN cohort was, or analysis for the IgN cohort was pre-specified. And so these patients were included in the CKD study, but were analyzed separately. And that's the data that's being shared on the left-hand side of the screen. The EMPA-KIDNEY trial was even a larger trial that enrolled close to 6,000 individuals, of whom 817 participants had IgA nephropathy. They did not publish the IgAN data separately. However, they did analyze the IgAN group in that publication. And it is, as you can see here, looking at the primary endpoint of sustained eGFR decline of at least 40% or higher, or reaching an eGFR of less than 10 milliliter per minute adjusted for body surface area, and stage kidney disease or death from kidney failure. And looking at this primary endpoint, again, the use of empagliflozin was very favorable in all subgroups, but particularly the one we're interested in today, IgA nephropathy. Another FDA-approved drugs for IgA nephropathy are sparsentan, which falls under this, again, non-immunologic therapy. And sparsentan is a dual antagonist of endothelin and angiotensin II receptor, and inhibiting both pathways. It reduces glomerular hyperfiltration and has effects on proteinuria and tubulointerstitial fibrosis. So as you can see, sparsentan technically targets HIT4 that Jerry mentioned earlier. Immunologic therapies include targeted release budesonide that acts on HIT1. Specifically, it affects the mucosal B cells in the ileum and therefore reduces the production of the pathogenic form of IgA and subsequently IgA immune complexes. Iptacopan is a factor B inhibitor that inhibits the actions of the alternative complement pathway, suppresses inflammation, again, prevents complement deposition and decreases proteinuria, and is thought to act on HIT4. And we'll talk about these drugs down the line. So let's talk about the PROTECT trial that was a phase 3 study, enrolled 203 patients that were randomized to the sparsentan arm, and another 203 patients that were randomized to the irbesartan arm. The sparsentan dose was 400 milligram per day, irbesartan 300 milligram per day, and patients had to have biopsy-proven IgA nephropathy with significant proteinuria of more than a gram per day to make it into the study. Of course, they had to be on a stable dose of ACE inhibitor and angiotensin receptor blockers for at least 12 weeks prior to screening and certainly prior to randomization. As you can see on the right-hand side of the slide, sparsentan resulted in significant proteinuria reduction at 36 weeks. This was the interim analysis for the primary endpoint of the trial. 49.8% reduction in the sparsentan arm versus 15% in the irbesartan arm, favoring the sparsentan group. The reduction, importantly, was observed as early as 4 weeks after randomization, again suggesting a quick onset of action. Looking at the more longitudinal data at the 2-year mark, you can see that the proteinuria continues to be sustained and reduced in the sparsentan group, much more so than the irbesartan arm. And you can see that the separation, as I mentioned, occurs fairly quickly, and that after the stopping the drug at week 106, the results seem to be sustained. Again, very encouraging results from the PROTECT trial. How about the EGFR effect? Here again, the irbesartan group fared worse than the sparsentan group. And at the end of the study, after stopping the drug, the EGFR results were maintained. It's worth mentioning that both irbesartan and sparsentan cause initially a small dip in EGFR that is expected from all these drugs that have hemodynamic effect and therefore should be expected. It happens quickly within 4 to 6 weeks of starting the drug. The other thing that's worth mentioning is that there is a REMS program in place. When you prescribe sparsentan, patients have to have liver test monitoring as well as they have to be counseled against any pregnancy, as endothelin inhibitors have known embryo-fetal toxicity that's quite significant. The PROTECT trial also tried to look at the chance of patients achieving either complete or partial remission. And complete remission was defined as a urine protein excretion of less than 0.3 gram per day, and partial remission as a urine protein excretion of less than 1 gram per day. As you can see, whether you look at any cutoff for proteinuria, less than 0.3, less than 0.5, or less than 1, all of these were in favor of the sparsentan arm. And you can see the chances of achieving these either partial or complete remission in each of the subgroups. Moving on to the NefIgArd trial that looked at the effect of targeted release budesonide in a phase 3 design. Patients here again were included if they had IgA nephropathy, biopsy proven, had persistent proteinuria despite being optimized on their RAS inhibition. The patients were treated for 9 months, so everything that is in the shaded part of the slide from month 9 to 24 is essentially on no treatment. As you can see, the targeted release budesonide at 16 milligram per day achieved significant reduction of proteinuria at month 9, and that was continued until month 12, where they showed even further reduction in proteinuria, so some sort of legacy effect even after stopping the drug at month 9. And as you continued through month 24, there was a slight uptick in proteinuria after stopping the targeted release budesonide, but still the proteinuria reduction was quite significant, about 30% at 24 months, even after having been off therapy since month 9. Looking at the EGFR data, this is again in favor of budesonide. And at 24 months, the placebo group had lost close to 12 milliliter per minute compared to baseline, whereas the budesonide group had lost about 6 milliliter per minute. Again, a significant improvement with treatment. How about looking at subgroups of patients? These were pre-specified stratifications by UPCR at study entry. And again, looking across all subgroups, whether patients had a UPCR of less than 1.5 gram per gram at study entry or above 1.5 gram per gram, the results were in favor of budesonide when we looked at a composite endpoint of kidney failure or EGFR of 30% reduction in EGFR, meaning worse outcome. So these results were consistent regardless of the baseline UPCR. So with that, I will turn it to Jerry to take us through the complement system and refresh our memory. The last time I had heard of the complement system before embarking on the IgA trial was in medical school. I don't know about you, Jerry. It's been a while.
I hardly heard about it in medical school. So I want to emphasize one thing that Dana said, and this is very important in taking care of your patients. And that is if you're using an ACE inhibitor or an ARB or sparsentan, you're going to get a drop in the GFR initially. The creatinine is going to go up. It's also important to realize this happens with the SGLT2 inhibitors as well, with dapagliflozin and empagliflozin. So again, if you don't warn your patient that their creatinine is going to go up, you'll get them calling you right back saying, "Oh, my GFR went down, I'm in trouble." Again, this is expected. Over time. You do better and better and better, especially with the SGLT2 inhibitors. It takes a little while before they catch up with the placebo arm, but they do better and better over time.
That's a great point, Jerry. Thank you for adding that. Yeah.
So now I'm going to turn to the complement system, targeting and clinical trials here. And this is a system, again, which everybody, thought, oh, esoteric, not important. Now we have many complement blockers and we're getting more all the time. So these are the three pathways here that you can see of the complement system: the lectin pathway, the classic pathway, and the alternative pathway. Now, the lectin pathway is probably the least studied now in terms of newer therapies. I mean, that even though it's an important one in terms of activating complement, we use the complement system to kill bacteria, viruses, all different kinds of organisms here. That's our protective mechanism. But it's also involved in many forms of glomerulonephritis. It's activated by the glomerular systems that are going on, and that leads to damage to the glomerulus. So the lectin system is a little less involved in this, and it may be involved, but we don't have therapies that are targeting it right now. The classical pathway is usually activated by antigen antibody complexes. And these immune complexes, whether it's in post-infectious glomerulonephritis or lupus nephritis, they activate the entire pathway. And again, you get down eventually to activation of the fifth component of complement. If you look at the bottom of the pathway, C5a is a very potent anaphylatoxin. That means it recruits polys and macrophages to wherever the site is. It also activates the membrane attack complex, C5b through C9, which punches holes in cells. So this is the way we fight these organisms. But again, you can imagine in the glomerulus, it create havoc. That the alternate pathway is always on at a low rate. This tick over cell process is always going on, again, to fight other organisms here that are invading the body. But unfortunately, if the system is cut loose and the inhibitors are not working, here again, you can get activation of complement where you don't want it, recruitment of cells, inflammation, and membrane attack complex. So, three different pathways. We now have ways to block these pathways. So this slide shows you the alternate pathway. And as I said, it's constitutively active. It's active all the time at a low level. We have inhibitors in our circulation that prevent it from being overactive. Many of these inhibitors, if you have a genetic defect, you've got the system going all the time. If you have something that blocks one of the inhibitors, again, the system will be overactive. There's an amplification loop, and it can go on and get more and more active. So that amplification loop, again, is very important. The alternate pathway is an ideal place to block complement because you can use specific inhibitors here and by blocking the amplification, get a major, major effect in terms of your action here. And again, because there are alternative ways of going around this, that the alternative pathway by blocking high up in the system can do a much better job. So this slide shows you here that the newer drugs that are approved here, we talked about sparsentan, we talked about targeted release budesonide. We're now going to talk about iptacopan. Iptacopan binds to factor B. That is high up in the alternate pathway. If you're high up in the pathway, you can be more efficient at blocking everything downstream. But again, they carry the risk as well of having more risk of infections because we need the complement system to prevent certain organisms, encapsulated organisms such as meningococcus, gonococcus, pneumococcus. And if you block the system too much, again, you would get more infections. And that's why these drugs have to be studied very carefully, and that's why you have to use certain prophylaxis in these when using these drugs. But we'll look at where iptacopan acts on this complement activation. So here's a diagram of the alternative pathway. And in this diagram, you see where FDA-approved drugs are acting. So if we look at this, all the way down at the bottom is avacopan. Avacopan is a C5a receptor blocker. It blocks, therefore, the action of the fifth component of complement, the A form of it, because it's divided into C5a and C5b, but the C5a, and by doing this, it can be very helpful in certain diseases, and it is FDA approved for ankylosing. In the middle, we have ravulizumab and eculizumab. Eculizumab was our first major complement blocker, FDA approved. That ravulizumab is a newer form of this that's longer acting. But again, they act on C5. That pegcetacoplan is a drug that more recently approved for certain diseases, and we'll talk about this. It blocks on C3 itself. So it's higher up in the pathway. It'll block C3A, it blocks C5, etc. And iptacopan is way up at the top of the factor here, blocking factor B, way up in the alternate pathways here. So potentially more potent, but potentially, again, you have to watch out for infections a little more. So this slide shows you the route of administration, where these drugs are approved, and which newer diseases are being treated. So if you look at them, the drugs that are mostly have been approved in atypical hemolytic uremic, which is a disease of, again, C3 and abnormalities of the alternate pathway, and paroxysmal nocturnal hemoglobinuria, which was formerly a uniformly fatal disease, again, by complement activation. But here, 4 drugs are approved for this already. IgA nephropathy, only iptacopan is approved. It is the only complement blocker approved, and it has a tremendous advantage over some of the other drugs in that it's oral. Again, with this way patients can take the drug themselves, they don't have to come in during a pandemic, etc. We mentioned avacopan, which is oral, but again, works way down in the system, where iptacopan works way up, at factor B, but that's approved for ankylosing. So again, we're getting more and more new drugs approved in terms of treating this system. There is a REMS program for iptacopan, and the REMS program is very important because, again, this is the risk evaluation and management program. But it says again that there's a risk of infection with these newer agents again, and you have to use antibiotics, prophylaxis, and get vaccinations. Now, we'll go ahead now and look at the applause trial. Dana will tell us about this new trial which led to the approval of iptacopan for IgA nephropathy, the first complement blocker approved for IgA nephropathy. Dana, all yours.
Thank you, Jerry. So let's review the data from the Applause trial. So this was a phase 3 study, a double-blind, randomized, placebo-controlled trial that enrolled patients with biopsy-confirmed IgA nephropathy. They had to have significant proteinuria despite supportive care, which for the most part was optimized ACE inhibitor and angiotensin receptor blocker. There were some patients that happened to be on SGLT2 inhibitors as well, stable doses at the time of entry into the study. Overall, the study enrolled 443 individuals who were randomized to oral iptacopan, 200 milligram twice daily, versus placebo arm. And this data that I'm showing you is the interim analysis that was done at 9 months, looking at the primary endpoint of proteinuria change from baseline. And this was planned for when 250 patients reached that landmark, 125 in each group. Of course, the study is ongoing because we're still waiting for the eGFR data that will be determined at 24 months. So again, let's look at the primary outcome of the interim analysis, the change from baseline in the 24-hour urine protein to creatinine ratio at month 9. A little bit about the baseline characteristics of these patients. This was a global trial that included patients from all over the world. You can see the 2 arms were well balanced. The mean age was 39 years of age. a good distribution among males and females. There was good representation from Asia, about 64 individuals in each arm, so about 51% of the cohort, again, representing what the IgAN population looks like. Patients were enrolled pretty close to the time of biopsy for the most part. So the mean time from the diagnostic kidney biopsy was about 1.6, 1.7 years. They had fairly preserved eGFRs of around 62 to 65 milliliters per minute, and the baseline proteinuria was 1.8 and 1.9 gram per gram based on a 24-hour urine collection. As I mentioned, virtually all of them were on ACE or ARB, more than 98%, and about 14% to 11% in each of the two arms were already on SGLT2 inhibitors. These patients were, as expected, they had severe disease, and so some of them had already been treated with glucocorticoid previously. Of course, you could not be on any other immunosuppressive drug at the time of entry into this trial. On your right-hand side, you will see the distribution of the MEST score between the two arms. Again, well-balanced groups. The MEST score was not required for entry into the study, but it's good to know that they had all sorts of lesions. Again, nice distribution, including patients who had some crescentic disease and very few, as expected, who had C2 lesions, so a high number of crescents. And here are the results. Again, the primary endpoint was looking at month 9. And you can see that this was in favor of the iptacopan arm, with the mean between the two groups at month 9 of 38.3% reduction in favor of iptacopan compared to placebo. In absolute terms, iptacopan resulted in a 43.8% reduction in proteinuria compared to baseline, and the placebo arm had about a 9% reduction in proteinuria. But you can see that the separation between these two curves again occurs fairly quickly. By the first month on therapy, you can see patients with iptacopan having significantly lower proteinuria than the placebo group. As I mentioned earlier, the eGFR data is still pending, and it is worth, again, reminding people what Jerry mentioned. Anytime you go on complement inhibitors, of course, if it's an emergency use of complement inhibitors, you have to be on antibiotic prophylaxis. But for IgAN patients, that would be quite unusual. So most patients should be vaccinated, and then you wait a couple of weeks after the end of the vaccination before starting them on iptacopan, or for that matter, any complement inhibitors. So these vaccines include meningitis vaccines, both serotype B, but also serotype A, C, W, and Y. And then you should have them vaccinated against pneumococcal vaccine, and in some countries against Haemophilus type B. So something to keep in mind. So in conclusion, I hope that we, emphasize that IgA nephropathy is a common form of glomerular disease worldwide. I think Jerry very nicely described the 4-hit hypothesis that describes the pathogenesis of the disease, and again, that allowed identification of targets for therapy, and that's part of the reason we have all these trials going on. The therapeutic options are rapidly evolving, so you have to stay tuned and keep up to date. And the guidelines will likely be updated quite frequently to again reflect the new agents. In fact, I showed you the draft, and as you can see, the complement inhibitor was not on the initial draft because the results from the iptacopan trial were not available to the guideline committee. So that will be added before the drafts are finalized. The complement system is important in glomerular diseases in general, including IgA nephropathy, and very exciting to know that iptacopan is the first complement blocker approved for IgA nephropathy, and it's an oral therapy. Again, as we mentioned, most patients prefer taking a pill than getting infusions. So, Jerry, I know we can barely keep up with what's going on with IgA nephropathy. Anything you'd like to add?
Yes. So, just one comment about why there's so much data on proteinuria. So, in terms of getting a reduced protein excretion, proteinuria has been a great marker for progressive disease. The more the proteinuria in IgA nephropathy, the more progressive it's been. And the FDA recognizes this, and therefore, as a first indication, they say reduction of proteinuria. If you do this, you can get the preliminary approval, but long term, you have to show that the GFR is benefited as well, and the creatinine is benefited as well. So that's why you see proteinuria data early, and then in the drugs that are approved and their final approval, the GFR is in there too. But that's wonderful that it works this way because, again, we're getting many new drugs for IgA nephropathy, and we probably will get many more coming along too, acting at different places in that four-hit hypothesis. So I think it's a wonderful time, an exciting time to be taking care of patients with glomerular disease and especially with IgA nephropathy.
So I want to thank you, Jerry, for joining me today and being the co-speaker for this wonderful program. I want to thank the audience for joining us. I hope you benefit from this program and you tune in for more peer review in the future.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by Purdue University. This accredited activity has been developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/XJK860.